I'm Dr. Jay Anders, and this is Tell Me Where It Hurts, where we discuss some of the big challenges in health IT and how we can solve them so clinicians can do what they do best, care for patients. I'd like to welcome everyone to another episode of Tell Me Where It Hurts. Today's topic is going to be talking a little bit about healthcare and generative AI. Actually, I'm going to talk about a lot of it. And the interesting thing that I've been reading or not reading about is how AI is going to either start to alleviate provider burnout or it's going to eliminate provider burnout by having this wonderful thing come and take care of all the issues that are in healthcare and healthcare documentation. Well, most of us who have thought about this more than about 10 seconds realize that that just isn't going to happen. And the interesting thing is that I've been in medicine for almost 30 years. The first 20 was spent as president of a very large multi-specialty group practice. And we had physician burnout back in the day when we had paper charts. So physician burnout and provider burnout is not a new thing. Now, I think EMRs have contributed to that to a degree, but I don't see a lot of interaction between the actual providers and the people developing AI solutions for those providers actually getting to what they really, really need, want, desire, and really what's going to make their life easier.
Right.
So today's expert is the Chief Product Strategist for Altera, Dr. Bob Taylor. He received his medical education at Ohio University and his residency training in internal medicine right here at Mercy Hospital in Pittsburgh, where I'm sitting. Interestingly, I did my internship there too. He furthered his training in biomedical informatics and fellowship at the University of Pittsburgh, and he has worked in a lot of places and has several years of experience in developing ambulatory and acute care EHR solutions. I would deem Bob an expert in documentation because he's been dealing with it for 20 years, and I've known Bob for a while. And he has a couple of patents related to structured clinical documentation, which is also quite impressive. And he's a Google Cloud certified professional data architect and has been dealing with this now for some time and how to search and find out what actually we can do with AI in healthcare. So, Bob, welcome to the podcast.
Great. Thanks for inviting me, Jay.
I think it's going to be a great conversation. Now, you've been in the industry quite a while.
Yes.
You've been in a lot of different places.
Yep.
Before we get into the history of EHRs and how they've evolved with all of this, tell me a little bit about your career path and how you wound up at Altera.
Sure. Many people would describe it as schizophrenic. I call myself a journeyman. I enjoy change and learning new things. So I can tell you, you mentioned my residency in Pittsburgh. That's where I decided to make the leap into healthcare IT. I can remember distinctly a flu season in probably 1998 or 99, where half of our internal medicine residents were out with the flu, and I personally had to handwrite about 25 admission history and physicals to the ward. Talk about burnout, right? Back then, handwritten notes. So I had a technology background, although I was pre-med in college. I had a minor in computer science and was programming all along. Actually, I don't know if I've told you this before, Jay, I took a year off between my second and third year, did a .com startup with my brother and really learned web technologies really early in the industry, mid 90s timeframe. So I started putting two and two together, looking at the challenges of written documentation, and started designing out an EHR system. It was pretty rudimentary, but we were using it within the residency program to create structured templates with some branching logic in it. I wound up at the end of that training program hooking up with Greenway. Greenway was a small startup at the time in Georgia with, I think, 10, 15 employees at the time. They had a practice management system. And we decided to join forces, and we built out the Greenway Prime Suite system. So that was early days, and then you mentioned some of the other things. I did similar things, developing a web-based EHR at EMDs, and worked at Allscripts for years and a number of other EHR systems.
So you've been around the horn a few times, really. Is that that's what that means? And
Exactly.
you're still doing it, which is also encouraging. So you've been in a lot of EHR platforms.
Yes.
And we've seen industry change, a lot of industry change, especially the last 10 to 15 years. It's just been crazy. How would you characterize the change in the EHR industry as you've seen it?
Yeah. Well, so there's a dramatic contrast between when I started and where we are now. The Greenway days early on were beyond fun. I mean, we were, working 80 to 100 hours a week. We had a big group of developers that were equally passionate and committed to true innovation. We didn't really have a lot of boundaries back then, right? Regulations were basically non-existent. We were completely focused on the user experience, and it was great to be able to do user-centric design, although the technologies were kind of limited back then. We're talking Internet Explorer 5, so building a web application was challenging, right? But we had a great group of developers. We had a lot of product managers with clinical expertise, and we had a group of investors that were all clinicians in our community. So we did a lot of rapid prototyping, designing, including all those stakeholders. A lot of that has gone out of the industry. I personally attribute a lot of that to what happened with regulation over the last 20 years. Especially smaller vendors with limited resources to commit to R&D. When you're spending 90% of your budget every year keeping up with regulatory compliance, it makes things difficult. And the challenge a lot of vendors have, the vast majority, if not all, have, is when you architect a solution, you create your information architecture, your solution architecture based on the requirements you're aware of at the time. And we have incrementally added in succession over the last decade in particular, requirements that none of us contemplated at the time. And the result is bloated systems with a lot of technical debt. The information architecture in particular becomes bloated. You start, putting duct tape and, glue in places to keep things together. And that's where we stand. There's a lot of promising technology, but we all, collectively have to address that technical debt before moving forward.
So tell me a little bit about the challenges you see in these systems going forward. I mean, we're dominated by a couple of major players.
Yeah.
And I'm a firm believer that somewhere out there is the next generation of EMRs that's going to put a lot of people to shame once they finally get released and physicians start using them. So tell me a little about the challenges that you see in the future.
Yeah, well, so from a purely technical perspective, most of the solutions on the market are, on-premise solutions. The total cost of ownership is fairly high. I think we all recognize that we need to move to SaaS architectures, software as a service, where the hardware considerations, the staffing, the expertise to manage systems is outsourced and done in a much more efficient way. And beyond that, just on the usability front, there is enormous potential to reinvent workflows that we collectively have been implementing over 20 to 30 years now, before we had the technical advantages we have today.
So being a doc and being a technical person at the same time, which is a very unique thing.
Yeah.
You have been working with clinical data for a long time. So you've been a medicine customer for a long time, multiple different ways as well.
Yeah.
So What are you seeing the role of granular clinical data, going forward? And in particular, it comes to mind that we're going to be exchanging medical records and should be exchanging medical records on a routine basis in a useful format. So where do you see that granular structured clinical data going in the future?
Yeah, so the common complaint we get from customers, and this is customers across all the EHRs where I've worked, is the I'm all out of clicks problem. And in defense of us on the vendor side, we didn't want that to happen, right? But there's been this convergence of clinical variables, regulatory variables, billing related variables that in combination kind of force a lot of discrete data requirements. Up till now, there hasn't been a great solution without forcing a lot of clicks on providers, right? So the data requirements aren't going to change. We still need discrete data for all of those, from all those different perspectives, right? What we need is radical reinvention of those workflows to facilitate that entry, leveraging the patient, leveraging AI in revolutionary ways to reduce the load on the providers.
Well, let's talk a little bit about Altera and the direction that you guys are taking in regards to just what you said.
Yeah. So our vision is to do exactly what I explained, right? Which is, or mentioned a second ago, right? Which is, we want to dramatically improve that user experience by facilitating rapid entry in more intuitive ways. And, most EHRs today collect encounter data in largely unstructured free text, right? All of the big players do this. The health summary type data, medication lists, allergy lists, that stuff is all structured and discrete. But this extremely important encounter related data related to, the subjective, the objective findings, the assessments, risk assessments, and all that are largely free text. So we have, two real goals with our implementation of medicine and Quip, which is, creating a solution that allows rapid, frictionless entry of that discrete data in new ways, while benefiting from the medicine interface terminology, giving us the US CDI compliance, right? Those reference terminology mappings that are required for value sets, for creating patient cohorts for downstream application.
I just was thinking, interestingly, when you talk about things like that, I've had a lot of colleagues recently, actually, talk about, well, I just want to talk into a microphone and let it happen. Well, it's interesting that they would even say that, given the fact that why did we create documentation to begin with? We just talked about all the regulations, which is absolutely, we got to comply with that. It's here to stay. And I have to tell my colleagues, too bad, we got to comply. But what's interesting about that is, what's the reason we document anyway? And I think we've kind of lost fact of why we actually do that. And it's really for three reasons. One, for the patient, so we understand a picture of what's going on. The second is for us, the provider, so we know what we've done and can support what we've done. And it's what happens to us if we step on front of a bus. There's got to be an accurate medical record going forward. So really, documentation has three functions, regulatory, but really it's patient for you and me, and then anyone else that's going to take care of these folks. So let's talk a little bit about generative AI, which has been absolutely a frenzy. I've been seeing all of the health advertisements about what's going to be talked about. I think that's next week at Health regarding generative AI and what it can do, what it can't do. Let's talk a little bit about some of the pitfalls that you have discovered when you're dealing with this.
when I initially started working late last year with the generative AI, I was, like everyone else in the industry, extremely excited about the potential, and quickly ran into some roadblocks that have been written about extensively. The If you spend more than 10 minutes with it, asking it clinical questions, you'll quickly realize that it comes up with some amazing answers and some really off the wall answers. And people have labeled that hallucinations, where basically if a question is asked where the knowledge was not included in its training, or there's some ambiguity there, it'll fill in the blanks. And it does it in a convincing way, right? So it's certain about its made up answer, right? But you as a consumer of that do not understand that it's fiction, right? Which is a real challenge. And after my initial testing, where I would give it, for example, some of the E&M coding scenarios, or just regular medical coding, asking it to take this dictation and give me a code. It'll give you codes, right? Sometimes they're right, other times there's not, and there's no way for an end user to really distinguish between the two. Now, the cool thing is there is a tremendous amount of research across all industries, right, to solve that problem. And there are patterns of implementation that directly address that. There's a lot of modeling around human cognition. There's a couple of different approaches, like chain of thought, where you treat the AI solution as an expert that needs defined rules that they can step through in sequence. And that chain of thought is really what we've wound up gravitating toward on our side. There are some more advanced models out there, and we'll be exploring them as they evolve.
So tell me what you see as the possible applications.
Yeah.
Basically now and maybe even going forward.
Oh, sure. Yeah, I mean, the first one that everyone is excited about is the ambient listening solutions, right? I mean, we literally have gotten contacted by dozens of customers about our plans related to this, and we are doing pilots with a number of vendors, and are hoping to implement that in the next 12 months. And for those listening who aren't familiar with nuanced DAX, or there's companies like DeepScribe and Ambience and Nabla. Those solutions allow you to start. The solution listens in the background. You have a natural conversation with a patient, and it creates a transcribed note. And we see that as potentially a huge improvement in provider efficiency, if at least the subjective portion of a note, chief complaint, review systems, HPI, can be collected in that passive way. So that's the first area we're looking, and we could talk about challenges related to that here in a second, right? But we're also looking, down the road, leveraging it as a second opinion source. So to help craft a differential diagnosis, right, in a complex scenario, not to make clinical, diagnostic decisions or therapeutic management decisions, but to provide, a second opinion in cases where, a solution is not obvious. But again, we need to vet those solutions. It's not something we're planning on implementing, in the immediate future. And there are a lot of other cases. We could talk all day about all of the potential. One of the things I'm excited about related to clinical documentation is leveraging templates, whether it be from, Quip kind of templates that are, patient focused, where I can feed that to a large language model and have, via a chat kind of interaction with a patient, ask a very structured set of initial visit questions or pre-encounter questions. That'll help with a physician burnout or care team burnout, having a lot of that information collected beforehand. So
what do you see some of the challenges and the pitfalls here? Obviously it's not going to work out of the box. We just talked about that.
Yes.
And And we've had conversations, you and I, about guidelines, guide rails, what do you want to call it? But it's that constraint of these large language models. So talk a little bit about that.
Yeah. Well, the first thing I was going to mention related to the ambient listening, we don't see implementing that as a complete replacement for legacy documentation solutions. We see the ideal approach being leveraging knowledge models, clinical interface terminology, like QUIP, right, like medicine, to be able to use for targeting of free text, so that we can map dictation to structured entry to ensure that those guidelines, those requirements for documentation are being met, right? So we don't see them as completely separate solutions. We see the ideal holy grail solution as being a hybrid of the two.
So, interestingly, you say that because right before we started this podcast, I was in a meeting where we were going through a lot of the QPP and CQMs that are necessary these days. And some are quite complex. There's a lot of data. So talk a little bit about how the approach of taking that free text cloud, I'm going to call it that, by the way, in my humble opinion, after reading thousands of notes in my lifetime, reading a free text blob is almost harder than anything else, because you're trying to pick out little discrete pieces of information. If that blob can be put in a format that I'm used to, then I can pick that information up very, very quickly as a clinician. So talk a little bit about, that little interaction there and getting that free text data into all of the things that we now have to provide data for.
Right. Exactly. Well, and the thing about a solution like QUIP and other products on the market that allow you to build a structured skeletal structure for a progress note or any other document type is, to your previous point, Jay, is predictable. When some other provider in your clinic reviews that note in your absence, right, they know exactly where that data is located. The subjective findings are here, the objective findings, the assessment and plan, compared to traditional dictation that we all did years ago, where it was all meshed together, and reviewing that note for you to parse out those individual data points would be difficult, right? So, now there is some capability with these ambient type solutions to parse out that data and put things logically into categories. But we still need to parse out, right, those discrete findings to make sure that a diabetic foot exam was done because the patient's a diabetic, right? Or, to make sure that any clinical quality measure related data is recorded, or the patient is high risk, right? They're a chronic disease patient, CHF, right? Diabetes, right? We want to make sure that we've addressed those clinical variables specifically. How do we do that, right? We're not going to ask the large language model to implement all of those business rules, right? It's not aware of the vast majority of those, and they are constantly evolving. We need to bake those rules into our underlying technology and allow the large language model to be the scribe, right? The most advanced natural language processing solution any of us have seen that can not just handle lexical variants, synonyms, acronyms. It can actually reason that, I have a field in my form. That's this. I have this free text blob. How do I answer that question? And in our testing, that's where it's amazing, right? It can reliably fill in those fields.
So I've also read a lot, and usually this is in not medical type informatics or structure, but it's mostly to lay folks that are out there saying that, I think that ChatGPT is going to replace a physician. It's going to replace them. I'll be able to, and quite frankly, I've seen some implementations now, or starting to see implementations, where you've got a chat bot answering medical questions for patients, which is a little scary in my book. So can you talk a little bit about that whole, it's rip and replace a physician for ChatGPT versus the approach that you and Altera are taking?
Yeah, it'd be one thing if it was a reliable source of knowledge, right? And obviously all of us have seen the test that it can pass the USMLE, and right, it does well on standardized testing, but there's no indication to date that it can replace the knowledge and experience of a provider who is working right hand in hand with patients. So our intention is just to augment, to give these providers a superpower, and in the near term, like I mentioned, to specifically address the challenge of taking what's in their head and translating that into discrete data that needs to be collected for regulatory, clinical, and billing considerations.
Well, I think that's the correct approach, in my opinion. I think that it has a lot of potential in that regard. And if it can, as the smarter it gets, the better it will be. But I'm curious how smart it will get over time. Yeah. It's going to be a real interesting thing to watch. Yeah. So what else would you like our listeners to know about what you're doing at Altera and TouchWorks, and where can people find out more?
Well, so we are planning to start rolling out a lot of this newer functionality in the next 12 months. We're hoping to be able to talk more about this at some upcoming shows at ViVE and HIMSS next year. It's going to be an exciting journey for all of us. I as a developer am more excited at this point going to work every day than I was in 2000 going to Greenway for the first time, because the technology is, the tools we have today, I think are really going to change everything.
So I asked this question of everyone we're getting close to the end of our podcast. If you had a magic wand and you could wave it and change one thing, just one thing in medicine, what would it be?
I would go back to what I said earlier about regulation. Give us as an industry 5 years. Don't change any more regulations. Let us refactor our code bases. Let us take advantage of the generative AI stuff. Let us truly innovate to improve our systems. We'll all be in a better place.
So if someone wants to get a hold of you, Bob, how would they do that?
I can be contacted by my email address, robert.taylor@alterahealth.com, or you can just go to alterahealth.com and go through our website to get contact information, or our friends at Medicomp can steer you in my direction.
Bob, as always, it's been a pleasure talking with you. I think it's going to be very informative to our listeners, and thank you so much for being on the podcast.
Great. Thanks, Jay. Appreciate it.
That's all for today. Thanks for listening to Tell Me Where It Hurts. Tune in to Healthcare Now Radio and Podcast Network each month for the latest episode. To learn more about Medicomp systems, visit our website at www.medicomp.com. You can also follow us on Twitter at MedicOmpSys or myself at MedicOmpDoc, or check out the show notes for links. See you next time.